good morning or a good afternoon. Happy to have you here. Oh, Cindy is saying aloha. It is 77 degrees on Hawaii Island today. Unfortunately, there was an 8-point earthquake near New Zealand and we're on tsunami watch. Oh no, well, we will be thinking about all of you over there in the islands. Stay safe, that is for sure.
I think that Anchorage had a 5.0 earthquake earlier this week or last week. Anybody here, if anyone's from Alaska, chat it in if that's correct. 5.3. Yeah. Yeah, you guys can chat to all panelists and attendees, then everybody can see it. It's fun to watch.
Oh, yeah, good call. Yeah, when you see in your chat window, it says to, and it'll say all panelists or all panelists and attendees, and then everybody can see where we're at. Okay, well, my watch is telling me that we are going to kick off our session today. We have a very full agenda, so let's get going. Welcome to today's presentation. We're going to be talking about self-measured blood pressure program, establishing a program, what are your steps, and how can you evaluate your progress over time? Keep those chats coming in. We do have all of the lines muted. However, I would like all of you to be here in the now and be prepared to share. Throughout the presentation, feel free to chat in any of your questions throughout. And I've got my trusty partner in crime, Patty and Patty and Deb watching the chat so they can answer those questions. And then when we've got a gap in the presentation, the presenters can definitely touch base with all of you. My name is Kristen Schuster. I'm with Mountain Pacific Quality Health. I'm a senior account manager. I specialize in practice transformation. I also have Jessica Newmeyer on the line with me as well as a co-presenter. She is from the American Heart Association. She is the Western States Community Impact Consultant. There she is. Perfect. Good to see you. Thank you. I would also like to thank our regional partners. This presentation today was in collaboration with Alaska Department of Health and Social Services, the American Heart Association, Hawaii Department of Health, Montana DPHHS, Montana Primary Care Association, Mountain Pacific Quality Health, and then also the Wyoming Department of Health. So lots of experts on the line. What are we going to talk about today? So the agenda that we're going to look at is looking at an overview and benefits of SMBP, looking at pre-implementation considerations before you launch into your planning and execution phase, and then how to prepare for SMBP implementation, and then what does implementation and patient engagement look like, and then how do you monitor your effectiveness over time. We also have two delightful practice presenters that are going to share their experience around establishing an SMBP program later on in the presentation. And then we're going to get some engagement from all of you to have a group discussion to kind of see where all of you are at on some other areas of opportunity where we can help. And the teacher in me always has a leaving in action and a little bit of a homework assignment so you all can get on your way for developing your own program. All right, before we get into the content, let's do a spectrum line. So if you're not familiar with the spectrum line, it's very, very simple. We're just gauging your familiarity with SMBP. So we are going to launch our polling question here in Zoom. So how familiar are you with SMBP? There is no wrong answer. Just choose whichever. All right, looks like familiar, somewhat. Okay, I like it. The Kentucky Derby girl that likes horse races in me always enjoys watching the polling answers come in. All right, so we got an expert on the line. So you're definitely going to be one of our experts in our discussion question later on. So that's very important. All right, so it looks like we've got a pretty good spread. So the majority of you have somewhat of a familiar, if not a familiar knowledge for SMBP. We've got some folks unfamiliar, and then we've got our one expert. So I think that means that this is a good, relevant topic. Okay, so let's get into it. What is it? So self-measured blood pressure is defined as regular measurement of blood pressures by the patient outside the clinical setting, either at home or elsewhere. The big stressor is the patient is doing this. So it does require the patient to measure their own blood pressure at different points in time throughout the day, utilizing their own device or one from the organization or practice, and then reporting those results back to the clinical care team. There's evidence-based guidelines that show that blood pressure monitoring, along with clinical support, really helps patients with hypertension lower their blood pressure. So there's kind of a three-pronged benefit here for implementing SMBP. There's the obvious with the patients. So with the patients, our goal is to increase patient engagement, improve upon self-management support, and then increase and improve upon medication adherence. For our providers and our clinical care team, the goal is to improve communication with the care team, improve patient outcomes, and increase quality measure scores. I'm also going to add that when you're looking at the quality measure score, perhaps your patient's control of hypertension improvement, CMS 165, you could also look at patients' utilization metrics. So perhaps patients with high inpatient or emergency department utilization could really benefit from this to really take charge of their own care and encourage them to get a nice relationship with their primary care provider to really improve those outcomes. And then lastly, of course, there is opportunities for increased revenue as we look at some of the billing codes that are associated with SMBP. We'll get into those a little later in the presentation. So things to consider before you get into the implementation phase. Like Deb, who said she's a little bit of a control freak, I also am. So prior to launching into any new project, a thing that I like to think about is, before we get into it, what are some things that we should consider to start to identify some potential barriers or kind of hiccups and workflows down the road. So first, looking at your budget, then looking at staffing. Who's going to do the work? Who's going to interact with the patients throughout this process? Who's going to be responsible for the billing components, and how are those claims going to be submitted, and how is that revenue going to be tracked? On the other side of things, we have the equipment and program structure. So there's a couple of different ways that you could look at doing this, or a hybrid of ways. So the blood pressure cuff, obviously, along with the patient, the cuff itself is a very critical component to this process. Some organizations choose to do a loaner program where the organization itself purchases the cuffs and then leases or rents those out to the patient. So kind of a checkout, like a blood pressure cuff library. The other is patient-owned devices. Some insurance companies do cover the blood pressure cuffs. Some organizations choose to have the patients purchase their own, and that's how they monitor them. And then you may come up with a hybrid, one of these two different scenarios. Something you would also like to think about is your EHR. How is this data going to be taken from the patient and put into your EHR in a way that allows you to track the patient's outcomes over time? You may find in talking with your EHR vendor that it's not possible to do that. So there are some third-party software vendors out there that may help with this in order to best gather data and share that information with your providers. Preparing for implementation. Communication is, it's at the top for a reason. It's not a coincidence. So communication is really critical, both from the staff perspective of really understanding what their expectations are in interacting with the patients, as well as interacting with the provider and other care team members. The patients need to have ongoing communication and have a very clear expectation laid out for them about what their responsibility is in this program and how they can move forward with it and really take charge of their health. Scheduling, obviously, how is this going to be done? How are we going to do the logistics? Workflows. So along with staffing and billing and all of those components, you'll want to think about workflows so it becomes a very efficient process throughout. Training. This also is broken down into staff. So with staffing, there are likely going to be new workflows, but care team members may also be working in a different capacity. As they work with patients around self-management education, motivational interviewing techniques may need to happen. There may need to be some additional training around that component to really ensure that the right folks are working with the patients to really optimize the overall process for SMBP. And then lastly, educating the patients. They're kind of doing a lot of the work. So, thorough education of how the blood pressure is taken, how it's communicated back to the care team, what's the expectation, really how they can be a very active member. And when I say patients, I do also mean, caregivers and family members. The EHR we already mentioned. Some organizations, lastly, like some documentation. So if there's a blood pressure cuff checkout program, you may require some documentation for monitoring that process, looking at materials or agreements to make sure that the patient is very clear with the role of the checkout. And then if you would like to do any consent forms, that's always a possibility as well. Okay, so before we get into the how-tos, which SMBP area do you have the most questions or concerns about? We're going to launch another poll and gather some more of your feedback. Okay. Budget, billing. Oh, all right, we're getting quite a few in there. Oh man, I don't have a clear winner quite yet, but it's looking like billing is kind of the main question. We do plan on utilizing this data to identify additional opportunities for learning and networking around these different topics. So I don't think I'm terribly surprised that billing is coming in first. I do like to see that the patient education portion is there as well. So I think that Jessica with the American Heart Association is going to demonstrate a lot of different great resources that are out there and available to you and your patients. Okay, perfect. Okay, so we have a tie. So billing and patient education, great. Okay, so with that, I'm going to turn it over to Jessica Newmeyer with the American Heart Association to get into the SMBP program implementation and patient engagement strategies. Hi, Jessica, thanks. Take it away.
Hi, thank you. Thanks, Kristen. So yes, we are going to dive into steps for implementation. So steps for successful implementation include number one, identifying which patients are going to be referred for your SMBP program. And we're going to get into each of these. Next, teaching patients how to perform SMBP. So that was perfect. That patient training was one of your main interests, because we're going to talk about that as well. Third, teaching patients how to perform SMBP. Oh, I'm sorry. The patient performs the SMBP. And then fourth, receiving the patient data. Fifth, interpreting the results. And then finally, going over the results with the patient. So I wanted to share on the next slide, yes, these SMBP implementation resources from the American Heart Association. This is on our website, and the website is targetbp.org. And on that website, you will have access to this self-measured blood pressure quick start guide. And this quick start guide has resources for you to get started implementing your SMBP program. The first resource in this guide, there is a link to an SMBP pre-assessment tool. And that tool helps you identify where you are with your SMBP program, where are your strengths, where are your opportunities, and where do you want to strengthen your SMBP program, or if you're just getting started, it walks you through different steps to get started. And then next, another resource that is offered is all around building your healthcare organization's knowledge in SMBP. So first of all, we recommend that you go to the website, targetbp.org, look at all of the resources that are there. And there's the patient measured BP section of the website. So there's a whole tab just dedicated to patient measured BP. And then we also have webinars that are available to you and your team at no cost. And some of the webinars that are on the website include, the first one is using SMBP to diagnose and manage high blood pressure, the scientific statement on blood pressure measurement, and then improving blood pressure control through policy. And then lastly, under building your healthcare organization's knowledge is a review, a one-pager of the CPT code. There are some codes that are all on a one-pager for you that may be helpful. And then, I know Kristen had mentioned potentially you may be thinking about or already implementing a loaner program. So on in this quick start guide and on the website, there are resources, there are recommended protocols, best practices, all related to implementing an SMBP loaner program. So a couple of the resources on there, there's a loaner device agreement. So that agreement, you don't have to create from scratch. It's already there and created for you that you can use. There's also a device inventory management tool to help you keep track of your devices and in managing the inventory of your devices. And then there are resources all around the device itself, the accuracy and device validation, including patient training. So the first one, there's a device accuracy test that walks you through making sure that a patient's device that they're using is accurate and is working for them. And then there's also a patient training checklist. So on that checklist, it's all the different things to keep in mind that a patient would need to know when monitoring their own blood pressure. And then also links and resources to those materials. And then also patient training checklists for a loaner program. So there's two separate patient training checklists. And then also an SMBP average calculator. So whoever is going to be receiving those blood pressure readings back from the patient, there is a calculator that can be used to average those readings. And then in terms of further patient education and training, there are loads of infographics that can help. One of them is just explaining what is self-monitoring blood pressure. There's a very popular training video that we have for patients that's available in a variety of languages. And the video trains patients how to actually take their own blood pressure. It explains what self-monitoring blood pressure is and walks them through the whole process of putting the cuff on and taking their blood pressure. And then there's also, if you're using recording logs, there are examples of recording logs and templates that can be used, so you don't have to create your own. So moving on to the first step of implementing an SMBP program, that would be patient identification. So identifying which patients you are going to be referring to your SMBP program. So here's some ideas you can think about when identifying those patients. Think about your data sources within your organization, your health IT platform. Perhaps that would aid you in finding patients that would benefit from SMBP. And then also thinking about input from your your care team, getting that care team input. They're the ones that are interacting with the patients every day and would have great input as well into which patients you might want to identify for your SMBP program. And then moving on to patient engagement. So furthering patient engagement, one of the strategies is to use that collaborative communication with patients. This is another webinar that is available on the Target BP website if this was something that you wanted to train or refresh your clinical teams on, but just some high-level reminders when engaging with patients in terms of communication. The first one being asking open-ended questions, and then reflective listening, asking for clarification. to make sure that you're understanding, or that they are understanding what is being said to them. Positive reinforcement, encouraging those healthy habits that they're creating, and provide, ask method. So asking what do they already know, providing information that will help them, and then asking for their thoughts on that information. And then teach back asks patients to tell you what they took away from the conversation. So did they hear what you were trying to convey to them? And did they hear what you were intending to convey to them? And then the collaborative goal setting. So including the patient when setting goals and health goals with the patient, asking for their input into the goals and into their action plans. And then following up, agreeing on a time for follow-up to monitor patients' progress. And so we found this quote that helps to underscore the need for that collaborative communication and patient engagement. So when your patients understand that you're interested in their struggles with high blood pressure and in their perspective on the matter, they are much more likely to be interested in what you have to say and to be open and interested in self-managing their high blood pressure. And so I wanted to highlight, this is a really popular resource for clinics that are implementing blood pressure, self-monitoring blood pressure programs. So this resource, it's an infographic, it's available in Spanish and English, and it explains in detail how a patient can prepare themselves for taking their blood pressure, position themselves, and then measure their blood pressure. And so the third step in SMBP implementation is the patient actually performs their blood pressure. So best practice recommends that the patient measures their blood pressure each morning and evening for at least 7 consecutive days. At each measurement, 2 blood pressures are obtained 1 minute apart. For patients with existing hypertension, SMBP should be performed 2 weeks after new medication started or a medication change. And then a minimum of 3 days of consecutive measurements is acceptable, and patients should use a data collection log to record their readings. If they're not using a log, perhaps you have a system in place where you have the Bluetooth monitors that are speaking to your EHR or uploading the readings into your EHR. But the most important piece of that is just making sure that those readings are getting back to the provider. And then speaking about receiving patient data, again, we have logs, but really there's a number of ways that the actual BP readings can get back to the provider. And so it's really going to be up to your clinical team to decide that and determine what will work best. And then in terms of interpreting results on the Target BP website, I just wanted to show you that we do have recommendations for interpreting SMBP results that you can see here. And gives these are the average of the readings, and these are the recommendations in terms of how to proceed with that patient. And next, I am going to turn it over back to you, Krista.
Oh, I'm talking on mute. Perfect. Thank you so much. Well, you have to love free resources and not having to reinvent the wheel. And I think Jessica gave everybody on the line a plethora of places to start, no matter if you're at the beginning or if you're in that expert territory. There are plenty of things that you can look at on that American Heart Association website, Target BP, to get you moving towards setting up a really good comprehensive program. So a couple of the codes, there were, Jessica mentioned that there were some infographics out there as well, but we did put together this little spreadsheet here. These are the SMBP CMS billing codes. So you'll want to think about your state Medicaid organizations as well as your commercial payers and double check with them to see if these codes are allowable. very similar to comprehensive medication management and care management. You know, there's some stipulations around how you can bill, how frequently you can bill, and what's required. So this is outlined here. Okay, so after you get through all of your implementation and you look into the process itself, how do you measure your outcomes? So first of all, looking at your clinical quality measures, something that you're already looking at for either your value-based payment contracts or perhaps if you're a PCMH, these clinical quality measures are a great way to look at your overall progress. You also can manually track data metrics as well. We're going to hear from our two practice presenters here in about 30 seconds about how they are tracking their patients over time. But some ideas that you can look at are kind of the number of patients that are in the program, the number of patients that are in control, the average improvement of patients in SMBP over time. Remember, providers like to know and see how their patients are doing with these new programs that are being implemented. So sharing that during daily huddles or established care team meetings is a really critical component to keep the train moving forward and keep that momentum. So with that, I am now going to turn it over to Deb Anderson, and she is going to introduce our guest speaker. Take it away, Deb.
Thank you, Kristen. Great job, Jessica. Great information to share with everyone, and I'm pleased to see that we have so many folks with us today. So I get the honor of introducing Tiffany Calvetti. Tiffany works for Dr. Carol Fisher in Cheyenne, Wyoming, and she has a few hats that she wears, including medical records and referral coordinator, hypertension grant program coordinator, and that's through the Wyoming Department of Health, COVID-19 vaccine clinic coordinator. So we're so happy that you would take some time and spend it with us today and explain how you've been implementing your SMBP program. Take it away, Tiffany.
Fantastic. Thanks for having me. We're really excited about the way that our program is turning out. It's a new program for us. We just started it this last year. We started out with 4 in-house blood pressure cuffs and found the need was out there that people didn't want to invest in their blood pressure cuffs. They just thought that the financial side of it was just more than they wanted. So we started the loaner program, and I started out with 4, and now we've got over 22, and all but I think 5 of them are out of the office at this moment. We check them out anywhere from 2 to 4 weeks, have them come back in, reassess, and then we'll recheck them out. I really, really like the targetbp.org site because there is so much information that's helped build this program. The forms, the information, the training, education for the patients, all of that is available right there. We can modify some of it so that it works for our particular demographics with our patients. The buy-in for my providers was actually pretty tough at first because nobody wanted to take on any more responsibility. And when they took that on, when I vowed to them that I would help them get this up and running, the thing that helped my providers buy into this program was that they knew that I was available to educate the patients on how to take their blood pressures at home, how to use their machines. The other big thing was for our patients to be able to download. The machines that we have on hand are Bluetooth capable. So they download to our EHR. Our providers can go in and check in on those patients frequently. I have an RN on staff that's our critical care manager. She checks with our patients about twice a month, just so that they know that they're cared for, that they're being watched, that we do see what's going on for them. My scheduling staff has been very helpful as far as making sure that if a patient calls in and they're on our program, that they get them on the schedule quickly and that they get cared for very promptly. We have a template set up in the system for our CCM that shows what patients are signed up with this program. Once they sign the contract with us, they're not tied into it. We make sure that they understand that they can, if they don't feel like they need the program anymore, we can sure sign them off on it and send them on their way. I built a folder that goes out with each patient that has a copy of their contract, a copy of their loaner agreement with us. It gives them a medication list so that the medication tells them, the list tells them what their medication is, what it's being treated, what it's treating, their dosage, when they're supposed to take it, what providers prescribe that medication for them as well. I give them the opportunity to work with our EHR. I also send a spreadsheet home with them for them to be able to fill out, so that if they don't feel comfortable, like their information is getting back to us, they still have a source. They bring it back in, they can fax it in, they can call it in. We just, as long as the patient understands that we'll take it however we can get it from them to help out, and we get it to the right hands and get them the attention that they need right away. I see somebody asked a question about the blood pressure cuffs. We let them keep them for 2 weeks. Unless they need them, we'll let them keep them for a month. I even have a couple that are signed out for up to 3 months. We will bring them back in, reassess them to see if they still need to be monitored that tightly or if they're making improvements. As far as the data, we've talked about how we gather that data into the system, how I bring it on board. We really struggled at the beginning because of COVID. We were trying to get this program up and going, and we had to go to half staff. Our patients decided that they didn't want to come in and visit in-house. So our EHR and being able to get them set up with their home to be able to dump that information right down to their charts so that their providers really, once they realized that we could do televisits and that we could take that information, then our numbers really started to increase, and the patient availability was there for us as well. It's looking up, it's growing. My providers are excited. The one thing that I do highly recommend is don't let them leave without having them trained right then. If I have to call them back in for any other reason, to set up their machines with them, to get their machines connected to their phones or to their iPads or whatever, I tend to start to lose interest. So don't let them leave until they have all of their information. I also take any of their other diagnoses into consideration. So if they need the DASH diet handout, they go home with that. Each time that they come in, I try to give them some type of education. The providers let me know what they want them to be educated on, if it's exercise, if it's diet, if it's sodium, if it's smoking, any of that type of information is all available to them to them for their education. So I highly recommend going into the targetbp.org site, because that'll give you a lot of information that you can help build the programs on. And Million Hearts has a lot of information as well if you want to go into theirs. So other than that, it's a great program. If you have any questions, let me know and I'd be happy to get them answered.
Hey, Tiffany, this is Patty. I did have a quick question. Do you have data that shows that blood pressure control did improve with the use of self-measured blood pressure programs?
So we are seeing the numbers, the blood pressure numbers are decreasing. The patients are starting to come in a little more frequently so that they can be treated. Their lab work is done more frequently. And yes, so there is numbers. I can't give you the exact numbers right now because I wasn't ready for that question. But yes, we are seeing some improvements in the hypertension.
Great, thanks. You're on mute, Deb.
Oh, Deb, you're on mute.
It wasn't the computer one, it's this one. Sorry about that. Tiffany, thank you so much. I'm going to hand it over to Patty so she can introduce our next presenter. Thank you.
Thank you so much, Tiffany, and thank you, Deb. And if you can go to the next slide, I'd like to introduce Susan Morgan, who's agreed to present with us today. She's from Montana, Northern Montana Healthcare up in Havre, Montana, and she is the Director of Clinical Nursing. So Susan, if you want to take it away, if you want, you can turn on your video. If not, either way is fine.
Hi, Patty. Thank you for introducing me. My name is Susan Morgan. I am the Clinic Director of Nursing here at Northern Montana Healthcare and have been here for about 4 years. We have done a lot of new and interesting things since I've been here, and it's been sort of exciting. Our self-measured blood pressure program started in September of 2019. It was very small. We had 10 blood pressure cuffs that we were going to loan out. And most of probably the first 3 or 4 months of our program was all about education of staff and providers. Since that time I still have to go back and revisit and remind, but our program grows pretty consistently. I have 10 new blood pressure cuffs in my office right this very minute, and we will have about 70 blood pressure cuffs, and when these get out distributed, that we use for loaner programs. How we do it here at Northern is patients are identified when they come in and see a provider. We do not use just primary care provider visits. If somebody is in the ortho department and he's a 27-year-old male and his blood pressure is higher than a coyote, and he really doesn't have somebody that he sees on a regular basis, is we don't want to miss out on any opportunity. And so conversations are had with anybody whose blood pressures that we have noticed have been high 2 consecutive times in our EHR. How we do it here is our medical assistant or our RN is identify what's going on. And I have a pretty robust care management service here. 3 people that work for me in care management that are pretty fantastic. If an RN or NA recognizes somebody needs to have some help, they will call one of the care coordinators and they come in, and we have it pretty much down, defined down to education that will be delivered, how it will be delivered, all the handouts they get, and so what they go home with. And so, for example, if a patient, his blood pressure is high or over the parameters, we will ask them if they are interested in this, and we would like to do a little bit of talking to them. And generally, my care coordinators go right in the patient exam room where they're at, talk to them about it. And if they show interest and say, yeah, this is something that they're interested for, we take them to our education rooms. The last couple of years, I've had a lot of little grants through the state of Montana, which has been really, really fantastic because we've never, ever had very well appointed education rooms before with evidence-based literature to support everything that we teach, but we do now, as well as we purchased, leased, contracted for an online patient education venue this last year also that we utilized. But the patient goes in and it's sort of funny. Everybody mentions Target BP. Everything that I use is from the Target BP website. When I searched and I looked, that is where I went, and that's what we found, and it works really, really well. So the patient gets a little bit of education about how to take their blood pressure. They watch a 4-minute video on an iPad that was bought through our program on taking blood pressure. And then we have them do a teach back. And so the patient actually explains to my staff how they're going to sit when they take their blood pressure and when they're going to do this. We utilize a self-measured blood pressure 7-day recording sheet right from the Target BP site. And what we request our patients do is go home and take their blood pressure twice in the morning, prior to coffee and cigarettes, if they utilize those. Feet on the floor, absolutely, I will. And then twice in the evening is 7 o'clock or whenever it's convenient for them, but twice a day. And in 7 days, we try to collect 28 blood pressures. The least that we will accept is 14, because 14, anything less than 14, we just don't get enough data. Our providers do not want anything uploaded into our medical record without them being known of it. And so is Tiffany, I'm amazed that your providers say, yeah, that's okay, but ours would, their heads would all explode. And so we don't do that. And so when we get the information back, the patient comes back and they can take a picture of it. As we get a lot of stuff via phone, by email, is they take a picture of the target blood pressure sheet and send it back to us. And what we do is we stick it in and we average blood pressures. Is we take all of the blood pressures in, we average them out. Then we send a note to the provider with the highest blood pressure on the sheet, the lowest blood pressure on the sheet, and then the average, and tell the provider how many blood pressures there was. If the blood pressure at that time is below the parameters, then pretty much as we reach out to the patient and say, you're good to go. The medications that you're on is exactly what the doctor wants you to be on. So please make sure you continue that. Thank you, Jessica. And then they bring the blood pressure cuff back, and we go on to the next one. Is if their blood pressure is outside of those parameters, then we go ahead and we talk to the provider, and the provider does it through my care coordinators with just for continuity of care. And they'll come back to the care coordinator and say, tell the patient I'd like them to start on 12.5 milligrams hydrochlorothiazide once a day in the morning. And so they put the order in, and then my care coordinator calls back and tells them is, you know, your blood pressure is a little bit too high. What the provider would like you to do is try this. We have also, when patients have pushed back on us and said, you know, I really don't want to take any medication. And then we do a whole bunch more education about lifestyle, DASH diet, what else they can do. Most people, however, really like the information about the DASH diet, what else they can do, but I would say that 90% of them take their whatever pill that we're starting them on. Is we ask them to take that pill for 10 days, right around 10 days. And so it's starting to work in their system, and they keep the blood pressure cuff all during this time. And then we do another 7-day run. We send them out another recording sheet, and we have them do all the same thing over and done with. We have had blood pressure cuffs out for about 7 or 8 weeks before we get the patient's blood pressure controlled. I love it because the patients become involved in their own healthcare. Instead of swallowing a pill their provider tells them to take, this really brings them into being part of the healthcare team, which is very important. Let's see, what am I else we're going to do? Identified. Is one of the things we noticed when we first started this is our providers are at Northern Montana Healthcare do not embrace change. They're absolutely not early adopters in any way, shape, or form. And so when we first rolled this out, because I could get no one to listen, I did it all through my nursing staff. Because honest and truthful, taking blood pressures, that is a nursing job. And so we could talk to patients because we're not prescribing, we're not doing anything, we're gathering data. And so my nurses started, or medical assistants started sending blood pressure cuffs out, and then we would start sending information to our providers, and our providers sat up and went, this is really cool. And so we have a huge buy-in right now. Periodically, I have to go back and remind everybody as I do my chart reviews, and I notice like 3 blood pressure is pretty high, and I go look for notes, and there is no notes. And so then is, for me, direct communication works the best. I send a note directly to that RN, to that medical assistant, and say, you know, Mrs. Jones has had blood pressures that have been outside of these parameters for the last 3 times she was in. Have you talked with her about our target blood pressure program? Have you done something? And then I noticed that for about 5 months, that's pretty well fixed going forward. And to answer the question that was just asked, we do utilize patients' own blood pressure monitors. We ask them to come in, and on Target BP, it has a blood pressure validation sheet on all the instructions on how to do it. And so we validate and make sure the blood pressure monitor that they're utilizing is correct before they go home with their home blood pressure cuffs. One of the places that we have found that we have a problem with, and I don't know the reason why, to be perfectly honest. I don't know whether it's our demographics or what, is I've probably had 20 blood pressure cuffs take long, mysterious walks into the great unknown, never to be returned. I mean, people won't return phone calls. On their agreement, they did agree to pay $100, but if you can't get a hold of somebody, that's a problem. We started about 3 weeks ago, and we've had a couple pushbacks about it, and that's okay, because I can't give these things away, I only have some big budget, is we've started collecting a credit card number. And then those files come to me and are locked up, and so nobody else has access to them. But right on their consent form, it says, you know, if I do not return this blood pressure cuff after 3 times, my credit card will be charged. And we have all of that information. Is hopefully that gets rid of people thinking, all right, I've had this for 2 months, and so it should be mine now. What did I miss, Patty? Did I miss anything talking about anything that you asked me to?
No, but you're sharing great information. Well, first of all, that's the first time I heard that people are charging for not returning blood pressure cuffs, because that has been a problem. So that's good. That's great information. And then the other thing that I thought was really helpful that you shared is the fact that you need to, in order for it to be sustainable, you have to keep an eye on it, and you have to keep going back and talking to the providers and reminding everybody while you're doing it. It's not like a one and done. So, so thank you for sharing. I think you did a great job. You answered all of our questions. Does anybody have any questions for Susan?
I think there was a question in the chat for both Tiffany and Susan about the initial visit with the patient. So how long is the first, let me see if I can scroll up here. So how long is your average educational session with the patient, initial and subsequent visits? So what does that look like?
The first visit is, we can do it in 15 minutes easily. The amount of information, because we don't want to overwhelm them. We pretty much want to do a little bit of teach back on a blood pressure cuff, say, you know, here is your chart, go ahead and I mean, here's your folder, and this is information in it, and then let us know if you have questions. However, the well-laid plans of mice and men, that's what I call this, is all right, I am going to designate 15 minutes for this. People really like to talk when they've got one-on-one attention. And so I have stepped out of my office to go rescue one of my staff, because they will send me an SOS because their provider is waiting for their next patient. And I will step in and finish the education. They want to know about DASH diets. They want to know about activity. Something we're doing right this very minute, I'm just going to share because I'm so very excited about it. We have another program that we're working on right this very minute that rolls right into our self-measured blood pressure program, and that's identifying hypertension patients that are hiding in plain sight. They don't have a diagnosis of hypertension, but their blood pressure has been high. And we utilize we do cold calls on those because it all comes out of chart review and reports, but we call people On that particular program, we have about 40 people right this very minute on it. And about 65% of the people that are on that program now have a diagnosis of hypertension. And while 40 people don't sound like a lot, it's a lot to the people that now are on medication that they need. And so baby steps. The next step that we're going to do is we're trying to enact a RN-led hypertension clinic. And we will be offering set education to our hypertensive patients over a 3-visit time period of about 30 minutes each. And so all of those things are coming together. We do not bill for our program here. Is as rural health clinics is that these are not billable codes for us. We can't bill any RPMs, remote patient monitoring, and or any of the CPT codes for blood pressure. But over the last 18 months, our CMS 165 has went for overall in our organization of about 52% of our patients being monitored and their blood pressure being controlled to about 60%. We still have lots of room for improvement, but that's a huge statistic that makes our providers smile a lot.
Great. Well, Susan, thank you so much for sharing with us today. I'm not sure about the billing. My understanding was CHCs and FQHCs could bill. That's those CPT codes for SMBP. If someone knows that, definitely go ahead and put it in chat. We'd appreciate it. And I'm going to just turn it over back to Kristen. You're on mute, Kristen.
Oh, thanks everyone. Gotta love that double mute. Gets you every time. Thank you, Susan and Tiffany, for sharing your experiences and truly your expertise. It's always great to hear, you know, those stories from the field and take some lessons learned and be able to, you know, make a better informed decision when you're looking at implementing your own process. So great sharing. Okay, so we're kind of running late on or a little behind. So I think we can just launch into just maybe one discussion question before we part ways, just to kind of get those wheels turning as you head back to your practice. So when you're looking at, no matter, you know, where you're at in your SMBP kind of journey, but in your experience implementing SMBP or in your exploration of implementation, what are the most important factors for success? So if you could like wave that magic wand and kind of have that that kind of ace in the hole, what do you think is the most important factor to having a successful program? And if we could have you know, even Tiffany and Susan, if you guys want to chat in what you think in your experience is the most important, that would be fantastic. All right out the gate, we have patient engagement. Yes. The self is pretty critical. Agnes said provider and staff buy-in. Yes, most definitely provider and staff. Love it. All right, patient engagement, provider and staff. You know, it's kind of one of those things. I work in the world of like longitudinal care management a lot, and it's really similar to that. You know, there's kind of 50% that falls to the care team, and there's 50% that falls to the patient. And if you have one side or another kind of lacking, you're not going to get as good of performance. So yeah, good provider buy-in, good staff buy-in, and good patient buy-in. Another thing that I think is important is like my little cliche that I like to say is baby steps to greatness. So maybe don't start out with your entire patient panel. Don't start out with all of your providers. Start small. Do small steps of change, and then start to grow the program. So I don't think Susan probably started out her program with 250 patients involved, but as she grew and those lessons were learned, then you can start to grow. Providers and staff, yes. Okay, oh, I like this. Kyla said one, ability to track results to prove ROI. Yeah, absolutely. I mean, showing effectiveness of a program is really critical to sustainability. You know, there's obviously the billing components. We touched on the SMBP codes, and there are those RPM codes as well. But if you're part of maybe an ACO, if you are an FQHC and you have your quality metrics that you look at, if you're in MIPS, if you're in CBC Plus, all of those are very much, you know, evidence and clinical quality outcomes are kind of at the core of them. So tying it back to those are great. Okay, Tiffany said here, we started with 5 patients for each provider and they decided to keep adding patients. Yeah, absolutely. I love the provider champion. Never ever underestimate a good provider champion. That's always critical. Love it. Okay, so then I think we've got a couple of minutes. Let's get into this last discussion question. It'll, I think, flow nicely, but what strategies and tactics are most effective to maintain patient engagement? Seems unanimous in our chat that the patient is a critical player in this. So what do you think are some strategies to keep them engaged? Oh, Patty said, listen to their needs. Consistent feedback from Agnes. Yeah, definitely. All right, who else on the line? What do you think is the most effective way to maintain patient engagement? Small goals, totally. Listen and call and check up. Tammy, I love that 3-step approach. Absolutely. Listening is key. With the small goals, I think that just like I said, you know, with all of you on the line, baby steps to greatness, you know, it's the same thing with our patients. You know, what's meaningful to them is probably not those clinical indicators like, you know, their blood pressure necessarily or their A1C. It could be something very simple of wanting to take their dog for a walk or play with their grandkids or their kids in the park. You know, those are some meaningful goals for the patient that, you know, if you get their buy-in and you can get them into this program, those types of goal setting are far more patient-centric than our clinical quality outcomes that we look at. Yeah, and Deb said, ask the patient what matters. Totally. Tiffany, I like what she said here, touching base and proving they are on the radar. Yeah, I mean, I feel like sometimes when I go to the provider's office, like I'm just kind of, I go in, I get out, and then I don't hear anything for a year. So having that, you know, consistent follow-up and letting the patients know that, you know, they're there is something really simple. In my past life, I set up a similar SMBP program at a practice that I worked at. And what we did was the 3 folks that were doing the SMBP project themselves, they had backlines. So when we gave the patients their DASH diet, their blood pressure logs and everything like that, they got the direct line to their care manager that was helping them with their blood pressure. And what that meant was they didn't have to go through the phone tree. They got to call their care manager directly and say, hey, I have a problem with my cuff. I've got a question about my diet. But it was something really simple like that. And we didn't find that many patients like abused that, but it was just a nice touch. Oh, Beverly, like that. So Beverly said, refer to what you talked about at the last appointment so they know you still remember. Yeah, absolutely. It's a pretty simple customer service thing. Remember little bits about lots of people. It's so important. Perfect. Well, thank you all for the discussion. It was a really, really great collaborative approach. And Tiffany and Susan, your expertise, again, so valued. Before we get into our closing slides, we want to kind of launch this last poll and see what your additional education needs are. So of all of the things that we kind of talked about, what do you want to learn more about? Feels like billing, I was going to say, I feel like billing is probably going to pop up there. Blood pressure equipment and the EHR, absolutely. So what we're looking to do here is possibly spin off into targeted affinity groups where folks with like interests and ideas can come together and really get into the nitty gritty of, you know, what does billing look like? What does the equipment look like? What's the most cost effective? What's the most patient friendly? So that's why we're kind of looking at what additional education resources we can provide with all of you. So it looks like workflow and staff and training and billing and reimbursement are our big ones. I don't think there's any surprise there. Perfect. Well, if there's something else that comes to mind that we didn't cover here in this poll, I think Patty chatted in, perfect timing, my email address. So if you would like to get in touch with me and you've got some ideas about what you would like to learn more about, please feel free to shoot me an email and we can move forward with developing some of those affinity groups. So leading in action. What do you do next? So no matter where you're at, I think there's always refinement and ways to improve the processes. So look at exploring, establish your organizational buy-in, review the pre-implementation or implementation guide, and figure out what areas you would like to work on within your organization to either improve the process or take a step in the direction. And then learning. These slides will be available to you. We also have a recording as well. Jessica from the American Heart Association gave a ton of great resources. All of those we have linked in the slides as well. Please feel free to reach out to myself or anyone else at Mountain Pacific or any of our partners. And then look at joining the SMBP affinity group, where we can kind of dig into and get a more comprehensive approach of how this implementation looks and how we can grow together. Here are some resources for all of you. So we've got our Target BP, Implement SMBP. We've got some great community health worker guides that are going to show you some different strategies for motivational interviewing, if that's not something that your care team has really focused on. So yeah, all of these resources are a great way to kind of expand your care team members' roles. So with that, to close out the presentation, I am going to pass it over to Patty. I would like to say thank you so much to everyone on the line for your time, and we look forward to seeing you in the affinity group. Go ahead, Patty.
Yeah, thanks, Kristen. So I quickly wanted to let everyone on the line know that we actually, our Mountain Pacific and our partners that Kristen talked about earlier, well, they're listed on the slide. We actually formed a regional chronic disease collaborative where we're working together, pulling our resources and working to deliver content and technical assistance to you in a more streamlined way. Next slide. So you'll be hearing more from us. We'll be doing some more education. What we'd really like to talk, so in addition to self-measured blood pressure, we'd be interested in knowing what other education topics you would be interested in. So we're gonna ask you to do one more poll, if you don't mind, Maynette, if you can pull that up. What additional education would you like to see from the collaborative? And this is pretty wide open for chronic disease management. If you would go ahead and let us know what you're interested in. Good, you can choose all of them that apply. This really helps us then develop education that is useful to you. We want this to be a valuable use of your time, and we want to try to utilize the resources as best as we can. So we appreciate everyone's busy. So thank you for that. Lifestyle programs and other community resources looks like the winner there. So great information. Thanks so much. Yep. And then I think one more, we just got to thank you and contact Kristen or Jessica if you're interested in participating in our affinity group, or if you have any questions or would like any assistance from us at all. Kristen, actually, I think you're taking us out, right? Or did I just do it?
I am.
All right.
I think you kind of did, but that's all right. It's always good to say a quadruple and triple and all of the thank you. So we recognize that all of you are busy out there. Everyone, please stay safe out there and healthy. And thank you for everything that you do to improve the lives of our patients. So take care and we'll all be in touch.